Hi, everyone. And thank you to Dr. Piantadosi. That was a very nice review of some of the things I'm going to put in context in terms of current policy. And do I have a, yes, I do have a clicker here, sorry. But maybe it doesn't work. Do I just tell you to go forward? Oh, great. Sorry. So here's what I'm going to try to cover. I'm going to talk a little about the ANPRM, standards of care, incidental findings, and big data. And I appreciate this opportunity to share just a little about what I see as the most sort of contemporary issues or open issues in terms of thinking about the current landscape. So for those of you who aren't aware, which I imagine are very few of you here in the room, there was an advance notice of proposed rulemaking related to the 45 CFR 46 that we all think about in terms of the protection of human subject research. That advance notice was posted in July of 2011. There was a request for public comments at that time, and that deadline was extended into October. I just wanted to note, given the previous comments, the subtitle of the current proposed rulemaking, Reducing Burden, Delay, and Ambiguity for Investigators. And I think that's speaks again to Dr. Piantadosi's comments about concerns that the regulatory process might be getting in the way of the conduct of important human subject research. So what I want to do is just review a couple of the key topics in the ANPRM, and it happens that we are going to be talking about many of these in depth today. So the first issue that's covered in the ANPRM is protecting subjects from informational risk. The idea here is that we have a number of different frameworks for thinking about informational risk. Informational risk with the rise of genomic research is going to continue to be a question. And one of the key recommendations from the ANPRM is to adopt the HIPAA rules as a universal standard. As I go forward, I'll share that this was one of the particular issues that many of the commenters have questions for. Importantly, for those who are thinking about research in oncology, one of the important distinctions that these proposed rules indicate is that de-identified data collected for non-research purpose, there's no need for consent other than that obtained at collection. So the sort of routine, a patient is admitted into the hospital, often given a form to review that de-identified samples may be used in the future, that will continue as it is now. The difference here is that the ANPRM suggests that data collected for research purposes with or without identifiers requires consent. And this, as well as the HIPAA universal standard, also garnered a lot of comments. So the next topic is calibrating IRB review to the level of risk. For those of you familiar with the literature on human subject research, this is a continued concern about the calibrating of the intensity of the IRB review to the amount of risk in the particular proposal. So one of their recommendations is to revise and simplify the approach to expedited research. For those of us who do human subject research, we know we have to submit a continuing review on an annual basis. This recommendation is to get rid of that, and then also to replace the category that we all now fondly know as exempt research with a new category of excused research. And this is also an effort to streamline the process where an investigator would merely need to report to an IRB. The assumption as soon as that report is made that they could move forward with their research, and the IRB then has an obligation to audit those requests over time, but the expectation would be that this would relieve the IRB of some of their review of what I think we would all consider research that, because it has little or no risk, should be going forward. Another important recommendation is the utilization of a single IRB of record for domestic studies of multi-study sites. Those of you, I'm sure, are aware that the NCI has been at the forefront of thinking about this in developing the central IRB mechanism. The two critiques that are highlighted in the ANPRM are that multiple reviews fail to improve the protection of human subjects research. an empirical question, but certainly certainly the sentiment that those multiple reviews really just lengthen the time of review, and a diversion of valuable resources. So if you have 10 sites, there are 10 IRBs investing time and energy in that review. So the idea here is to consider other ways to review those multiple studies. I'll note here that just this month, the NIH announced a funding opportunity for empirical research on ethical issues related to central IRBs and consent for research using clinical records and data. So I take this to be an endorsement of the idea that while we are pretty sure that there are things that we can improve in the IRB system, maybe there are empirical questions we can ask to encourage the adoption of more central IRB mechanisms. The next recommendation is the improvement of consent forms and process. Again, those of you, I'm sure, are familiar with the many decades of research that have indicated that there are a whole lot of ways that we can improve consent and process, and during session 2, we'll hear a lot about that. The next is the establishment of an improved and more systematic approach for the collection and analysis of data on unanticipated problems and adverse events. Again, those of you who are active clinical researchers know that there are a whole lot of definitions out there related to these issues, and the idea here is to try to make that more systematic and universal to avoid duplication or replication of effort. 2 last recommendations in the ANPRM. Again, those of you familiar with the critiques of our current regulatory framework will be familiar with the idea that there's a thought that the common rule ought to be expanded to cover more research than it currently does now. I think this was recommended soon after the original common rule was published back in the 80s. So we have again, a recommendation to do that. And the final recommendation, again, I think with an eye towards facilitating research, is the improvement and harmonization of regulations and related agency guidance. Again, those of you in the clinical trial setting will know that FDA might say something, NIH says something, another agency says something, a program says something, and it's hard to try to manage and respond to all those. So again, the idea of streamlining some of that regulatory guidance. So what I wanted to highlight here is that in response to the ANPRM, there were more than 1,100 comments. While I would have loved to review them all as a social scientist, that wasn't something I could do in the interim. But what I wanted to do was share with you just 2 sets that I think are particularly relevant to this group. There was one comment, a joint comment from the American Association for Cancer Research, American Society for Clinical Oncology, and the Association of American Cancer Institutes. And as I noted before, while there is general support for many of the recommendations, in particular, they highlighted a need to delineate the responsibilities of the IRB of record. For some of you may, if you are on an IRB, there is a bit of empirical evidence that IRB members trust and value the review that they do, that may not have the same trust of other IRBs. So there was a concern here that there needs to be some delineation of these responsibilities of the IRB of record. So some of those concerns might be addressed, but there are clearly some deeper issues to consider. And then their overarching concerns was that they disagree with the adoption of HIPAA as the universal rule for privacy protection, and also consideration needed regarding the consent requirements for that de-identified data. I also wanted to mention that the National Research Council Board on Behavioral and Cognitive and Sensory Sciences had a workshop and report. The report came out last month. It's a lovely review from the perspective of behavioral and social science. So it's not as particular to clinical research, but it also considers some important recommendations. So one really important thing that they highlight is that there remains some concern, especially on IRBs, how to think about human subjects and research. In the regulations, they are set out as 2 different things. They thought it would be important to think about this as one concept and to provide criteria about that. They really like the idea of excused research, as you can imagine, but they also thought it would be important to operationalize some of the procedures for that. They too, along with that joint comment, were not excited about the adoption of HIPAA as a universal standard, and that there should be reconsideration of this idea of consent for de-identified data regardless of source. I wanted to just note that the Office of Budget Management and Budget, which is the keeper of dates, expected the next piece of this puzzle, the Notice of Proposed Rulemaking, back in October. That has come and gone. When that does come out, there'll be yet another request for public comment. And after that, I think most importantly, is that once that rule is drafted, it has to be reviewed and approved by all 15 agencies that currently endorse the common rule. So it took about 10 years, from 1981 to 1991, for the current common rule to be approved. I share with you a comment from Tom Buglisi, who used to be at the Office of Human Research Protection, is now over at the VA. He is very pessimistic about whether or not any of this will be moving forward. I tried to gather some information about what the timeline is here, and perhaps some of you are better hooked into this than I, but generally there's not much hard data on the current timeline. I wanted to mention just a couple of other topics that are in the news, as it were, that I think are relevant for this group. The first is a interesting, to say the least, conversation about standards of care. So those of you may remember the considerations about the support study. As a result of that, DHHS created the opportunity for a public meeting and request for comments on matters related to human subject research and standard of care interventions. So the support study, as you may recall, some might categorize as a comparative effectiveness research. There was an idea that there was a standard range that might be beneficial to very tiny premature babies in terms of the oxygen that they receive. There was some manipulation of those oxygen saturation measurements, and they followed those children to find out if there were better or worse outcomes. Some saw this as a research project that required a fairly elaborate consent process. OHRP found fault in that process. Others on the other side said, look, you know, this was a standard range. We tested out standard procedures. Needless to say, there's been a lot of comment in the literature about this, but I think that it has brought up a lot of really interesting issues for us to consider, especially moving forward with more practical trials, sometimes referred to as comparative effectiveness, as we move forward. So what does count as standard? What does that mean in terms of how you need to provide informed consent, et cetera? The other trend I'll mention is, as I said, comparative effectiveness. PCORI has funded quite a bit of comparative effectiveness over the last couple of years, and there's an interest in, again, streamlining consent or thinking about different models of consent, especially for these trials where you're testing head-to-head two treatments that may be considered standard. How much then do you have to share with the potential human subject when, if they came into the office, the physician would really have no reason necessarily to choose one or the other. I wanted to also highlight another very recent report from the President's Commission. They have been working for a number of months on the topic of incidental findings and came out with a report recently. Their overall recommendations in terms of, so the general topic that they're talking about is when someone comes in for a clinical visit or a research visit, they undergo some sort of assessment, procedure, test that identifies something that we would consider as incidental, not primary or maybe even secondary to the research question. What are the obligations of the investigator to disclose that information? What type of information is the subject going to want to expect? So they came up with some overall recommendations, appropriately, I think, reviewing all the current literature that has happened and draw on all of that and put a couple of things together. Their overall recommendations is that it's important to inform those who are being tested, that we ought to develop more evidence-based practice guidelines. We need additional empirical research. We need to educate stakeholders, and we ought to think about justice and fairness and health inequities as all of this new technology is adopted. A couple of nice things that they do in their report. The first is that they have a nice taxonomy that they have, again, drawn from the current literature that highlights expectations for the investigator in this case in terms of, do I have to report or not? So it has a nice, I think, 5 categories of different types of results that one could encounter and has some recommendations. It doesn't solve the problem, but I think it sheds some nice light on it. Another nice thing that they do is look at clinical research and direct-to-consumer recommendations, and then break that out by genetic sequencing, biological sampling, and medical imaging. So for those of you interested in incidental findings, it's a nice, they both highlight some theoretical concepts, but also have some lovely sort of practical guidance for those in the field. The last thing I wanted to highlight is this concept of big data, one I'm sure you're all aware of. I can't quite put the pieces together on how this might be a particular issue as it relates to oncology research, but it's certainly something out there in the human subject world of thinking about what if any of this research going on with this data ought to come under the rubric of any sort of oversight or regulation. Much of this data is publicly available, whether we know it or not, and efforts to bring that together. I would say that the one thing that I think is more relevant given this topic to the field of oncology is how we begin to use social media in terms of recruitment and tracking of subjects or follow-up with subjects. So there's some interesting debate in the literature about what is an ethical use of something like Facebook to try and track or retain subjects. So that is my review of the sort of contemporary landscape, and I also hope that you'll see that there are many of the topics that we'll explore in much more detail as the workshop moves forward.
We're a few minutes ahead of schedule, and Holly's indicated she might take a question or two if there are those from the audience. Okay, well, seeing none, then I think we'll move on to the next element of the workshop, which is a session on the revised HIPAA privacy rule. And that's going to be moderated by Tom Keene, if I could call Tom forward.